So it is my honor to introduce Kristin Scheeler. So Kristin graduated here in 2005, and she was one of my, I got here in 2003, so she was like one of my first students. And she worked on my research, my hospice research, and I've been lucky to stay in touch with her, and I'm very proud of the work that she's doing, and she's working with a good colleague of mine nationally.
Yeah.
And so I think it's great to have her here. And she has worked like 11 years now in medical care settings. You worked for hospice. Before that you worked at, was it called Wisconsin Care Wisconsin?
Oh, no, it was West Madison Senior Coalition.
That's what it was. Okay.
Yeah.
And then hospice, and now UW. So she's going to talk to us about medical social work today and some of your work, cancer thing.
Sure, yes.
Good. And there's some water too if you want.
Okay. Thanks. Yeah, pardon me. My daughter's good at sharing, so I have her cold or whatever this thing is, so pardon me if I'm not quite loud enough. Can you hear? Okay. So basically, Tracy just sort of asked me to talk about what do you do as a medical social worker, kind of what is your day like, how is it working with other professions, what are the challenges and perks of the job, and you know, sort of just what do you do as a medical social worker. Is anybody working in medical social work or interested in it? Well, working in first. Okay, but maybe interested. Okay, got it. I shouldn't ask two things at once. Bad.
And I'm supposed to ask you too if you're supervising any of our students.
I am. Yep. I have a student who's in the health placement right now. Yeah. So, and I had one other a couple years ago in the job that I'm in now. But so just two in the oncology job that I'm in now. But in any case, I thought I'd just sort of start with medical social workers are they're anywhere that medical care is being received. So, and that's broader than people think sometimes. So home health or home hospice care, so where you're going to visit people in the context of their homes. And that their home could be an apartment, a house, a care facility, or another environment, whatever that person calls home. You might find social workers in a skilled nursing facility, either for rehabilitation or long-term care, or a nursing home is another word for that, or in a community-based residential facility, which is also considered assisted living. You might find people in a hospital or an intermediate care hospital, so one where people aren't quite meeting the acute care needs of a regular hospital, but still need a lot more help than they could maybe get in a nursing home. So like there's a place called Select Hospital here in Madison that kind of meets that intermediate care hospital. UPC, social workers in outpatient medical clinics, either in primary care or specialty care. I feel like in Madison, mostly we see people in clinics in specialty care, like geriatrics, oncology, neurology, things like that. We would love to see more social workers in primary care, though. I think there's so much to be said for prevention and preventative kind of work. And actually, pardon me. And then you'll also find social workers in mental health inpatient facilities where both medical and mental health skills are needed, and also in AODA facilities where you might need both the mental health and medical knowledge. So medical social workers can do lots of different things during the course of a day. So you may do rounding or reviewing of a person's medical needs for that day with the medical team, so doctors and nurses, or what they call mid-level professionals, so either nurse practitioners or physician's assistants. Those are considered mid-level practitioners. You might kind of get a feel for the person's psychosocial status and their current needs that day. If someone's in the hospital, you might be working towards helping them get ready to leave the hospital. Or if they're going to be there for a while, you might help on somebody with their coping skills while they're in the hospital, or their continued sort of needs while they're there. Social workers lead family meetings at sort of these critical decision points in a person's medical care. So again, maybe leaving the hospital, maybe coping with a new diagnosis that is really going to impact the rest of their life or their life for a while. We really do conduct those, person and environment psychosocial assessments. So like that stuff you learn in school is totally relevant. And I use it all the time. So it's very, very good to get this education, and because you will use it. And you might need to do that multiple times over the relationship with the patient or a person, because things can change really rapidly when somebody's having an increased need to interact with the healthcare system. You also might assist or educate with regarding to advanced care planning or advanced directives, or any documents that might be related to medical care. You might just respond to sort of on-the-fly requests from anybody, whether it's a patient or a person themselves, the family member, a doctor, a nurse, a psychologist, a mid-level practitioner. You could get a request from really anybody in that medical setting to help with something. And then also you collaborate closely with nurses, physicians, occupational therapists, case managers from the community. So it's really good to kind of, once you start working, kind of keep up your contacts with people, because you never know when you might need a little assistance or guidance from somebody that you've worked with in the past. You might work with nursing assistants or medical assistants, dietitians, or other health professionals. And sometimes the medical social worker is in the place of educating and providing emotional support to those professionals too, not necessarily just to a patient of the system. And sometimes that education can be about the services that a social worker actually provides to the patients and families. And sometimes it's more about the role of the social worker. I know there's times when I've had There's times when a well-meaning nurse has asked me to just like fix something for somebody, and again, they're well-meaning, but I always ask, but did the person themselves want that or ask for that? And a lot of times they go, well, I don't know, or I just think they need it. And so I go and talk to the person, and it can go either way. No, I don't need help with that. Or, well, yeah, that'd be okay. And then I wait for that permission to help somebody with something. I don't just assume somebody's going to want whatever somebody else thinks might be good for them. Social workers in medical setting might facilitate support groups for patients or caregivers or both, and I do that. You might facilitate education about public or private benefits that might improve quality of life, whether that's financial quality of life, emotional quality of life, etc. You might conduct education or conversations rather about end-of-life care, quality of life, or palliative care. And you might kind of help empower people by providing language or information that they might want to use with their providers to help them navigate the system that they're trying to navigate. I feel like I do that pretty often, actually, give people the words to use when they want to try to get whatever they want to get done. You might also just assist somebody who's unable to navigate the systems or benefits on their own with either part or all of that navigation. So sometimes that can mean helping people access information about signing up for Social Security Disability or Medicaid or Medicare, understanding what those all entail, and either sitting down with somebody either at a computer or with some paper and helping them fill out the application, or not. I mean, sometimes just knowing that they can access the benefit and kind of how to start accessing the benefit is enough for some people, and other people need a lot more hands-on. You might identify just sort of overall needs in your specific setting and work to become more knowledgeable about those needs and issues that are facing the people that you serve. And I like that this kind of learning is never done. Like, you're just always learning more about it. So my setting that I work in is it's oncology social work, but specifically I'm mostly working with bone marrow transplant patients. And not only is that a complex kind of care or complex treatment to need, bone marrow transplant is changing all the time too. And so kind of understanding how that can change, and the other thing about bone marrow transplant is it can, depending on the type of bone marrow transplant, can change somebody's life forever. So sort of understanding whether or not that might be an issue for somebody, and what what that change might look like for somebody and how they might need to help themselves plan based on the potential for that change being lifelong.
Can you give an example of kind of a situation?
Yeah. So a situation of
Where how it impacts.
the rest of your life, how bone marrow, well, so in particular, there's a type of, like if you get a bone marrow transplant where you're getting stem cells, so, and these are not embryonic stem cells, just stem cells that come out of your bone marrow. You give them, if somebody gets them from another person besides themselves, they can sometimes have a problem called Graft-versus-Host Disease. And this problem can be mild to the point that somebody doesn't feel something wrong with their body, but that it's affecting their body chemistry or it's just sort of their overall health, but only the doctor can see it with blood tests. Or it can be severe to the point where it can, bring somebody close to dying, or it can impact somebody physically for the rest of their life in that they cannot return to the same kind of work that they used to because they're so fatigued, or they lose their ability to breathe well enough to do the sort of work that they used to do. They might not, a lot of people with graft-versus-host disease find that they can't rely on whether it's going to be a good day or a bad day in terms of being able to reliably go to work or something like that. So anybody who's getting this allogeneic transplant where they get a donor to donate to them needs to know that they may need to plan ahead. And not only that, but the recovery from an allogeneic transplant is 9 months to 3 years, depending on the person. It's a very long recovery. So it's preparing people for that too. A lot of people think, I'll be back to work in 2 months. And despite trying to explain that that's probably not realistic, people don't always believe that until they're in that situation, but at least we can try to educate. And we're kind of starting to learn as a team that if the nurse educates and the social worker educates and the doctor educates and the person hears it enough times, they maybe will start to remember and believe it, but it's hard to absorb and remember and believe when you're sick. And in many cases, this allogeneic transplant is the only way somebody has a chance of living long term, because it's given to people who have acute leukemias that would otherwise lead to death probably in 6 months to a year if things go well. And if things don't go well, acute leukemias can cause somebody's death in weeks after diagnosis if they don't get the right treatment fast enough. So it's definitely scary stuff. So then you asked kind of what was it like to work with the other professions, and I was saying, well, each profession has its own worldview and its own code of ethics and its own variance in terms of how they follow their own code of ethics, or if they even know it. And that's one of our primary grounding values, is to follow our code of ethics. Not so much necessarily for nurses all the time or physicians. In some cases, I think they don't realize they have a code of ethics associated with their profession. So there's that, so the values of the other people that you're working with. And then there's also these power differentials in healthcare. Somebody who I guess depending on their licensure and their ability to provide different types of care, somebody may have more power than another person with a particular patient or person. So a person who really values somebody being able to provide a treatment and provide medication will, typically assign a little more value to a doctor or a nurse practitioner or somebody who can prescribe medications or do procedures or offer, kind of hands-on medical intervention. So, and it does typically sort of work that way, that doctors tend to sort of have the most power in a healthcare situation. Not always. It depends on the setting that you're in. So I find that a setting like hospice is more interdisciplinary, where people kind of are seen a little more equally than they would be in a hospital, where it's kind of like the doctor has to sign off on the last, or has to sign the last word on everything that's done in the hospital, really. And in a hospital, everyone tends to work more in a multidisciplinary kind of, what did I call it? Silo. There we go. Silo. Versus a hospice is where maybe everybody sort of works together and uses each other's professional knowledge to help people. So depending on the setting, it might be different in terms of sort of power differentials. And sort of what I said when I was writing, I sort of wrote up some notes for myself. When I said, you know, social workers need to approach medical social work with like a confidence that they do bring value to the role and that they are leaders as social workers. And this is something actually that I learned partly through a workshop that I did working with Tracy's colleague Brad Zebrak. But leadership is possible from any place within the organization. Just because you have, you know, maybe don't have the title of leader doesn't mean you can't be a leader. And I think it's really important to earn that leadership, not just have it, you know, placed upon you. It's not something, it's something that you earn. It's not something that is just granted. So along those lines then, social workers can prove that they're leaders and that they value their role and they value the profession by relying on scientific literature and making recommendations for interventions with people rather than just sort of, oh, this feels right. Why? Maybe you can find a reason why, and so that's why we always talk about using evidence-based practice whenever we can. It's really important to do that. And not only that, ideally social workers should be contributing to research and contributing to the evidence-based practice. You don't necessarily have to be a PhD to do that. I've seen so many, since I've started working with the Association of Oncology Social Workers, so that's another thing, if you can get in touch with a professional organization that kind of matches up with where you're interested in working within medical social work, you can get, there's so much benefit to be gotten from that. But in the Association of Oncology Social Workers, tons of people are just MSWs who are doing research, or they're collaborating with a PhD psychologist or an MD or a mid-level provider to do research. And it's really important, and I think necessary that people do that. That's sort of, for me, I haven't really done too much of that yet, but I hope to. I've done what we have to call a quality improvement project because it prevents us from having to go to the institutional review board and really calling it a research project. But even that, it can be considered a level of research, and it's really important to gather your evidence and legitimize really what you're doing by doing that. And then the other thing that I sort of thought about was, I don't feel like any social worker is ever too seasoned or experienced to no longer need a mentor. You always need a colleague or some kind of mentor to conference with or reference to or talk to. And I feel like all the really excellent social workers I know have several mentors and esteemed colleagues that they turn to when they need advice or information or to sort of talk about a case or to kind of figure out what to do next. So, so that's when I said, oh yeah, join the professional organization that's relevant to your position, or NASW, and if you can and have time, become active in the organization, because you'll really see how social workers can make a difference and how you can really make the most difference and be the best you can be in your position. So challenges of the job. I find that sometimes there has been a little bit of a lack of buy-in from other professionals like nurses and doctors and other professionals that social work brings its own particular value to care. I've had to prove by doing that it's valuable and by educating, but mostly it's by showing the team that I can bring some value to the patient's care. So I had this one nurse that I was working with in bone marrow transplant. Well, she's still there. And she still does this to some extent, but I feel like I'm slowly winning her over. I've been at the bone marrow transplant job for 4.5 years, and I'm still winning her over, but we'll get there. But she kind of was like, oh, I tell people about the Leukemia and Lymphoma Society, you don't have to do that. Well, I found out she was telling people about this $100 grant that they could get for transportation money to drive back and forth to their appointments. They offer so much more than that. And so when I'd get to sit down with people, I'd say, oh, did you know about the copay assistance program up to $5,000 or $10,000 reimbursed to you if you qualify, and if you can use this program. Oh, did you also know you can learn about your disease and your clinical trials? You can get set up with a mentor who can talk you through stuff as you're going through treatment and care. And people very often have said, why didn't I meet you sooner? And it's just like, I'm sorry. So we have a new process in place actually where I do try to meet everybody before their bone marrow transplant. Hopefully, I still miss a few people, but so be it. Sometimes it happens. Sometimes there's a challenge due to lack of time. So I think that's in every social work job for sure. Patient schedule's really busy. Like they just have tons of tests and procedures and there's like no time to slip in to see them. Or the patient isn't feeling well and they just like can't concentrate on what you're saying. Or they're feeling anxious to go home and they don't really understand why a social worker would be valuable for them to see. And that's when I found I've had to like develop these like sales skills. And let me sell to you like why it's important for me to talk to you, and look at this thing I could offer you or give you or hook you up with. And a lot of times people, after they realize that there might be something in it for them, they will talk to you longer. But sometimes it's having that little bit of, how could I help you today? Some patients are worried about the stigma of seeing a social worker. I've had that quite a lot where they're like, I'm not crazy, I promise. Or, don't take away my children. Or, what did I do wrong? Why do I have to see you? And I'm like, sometimes people are sort of joking and sometimes they're really not. So I try to just be kind of casual and on that person's level and, let's just talk about, I just have a couple questions for you and you just ask me questions and, hey, did you know about these resources or this benefit to you? Or, yeah, I like talking to you, because more often than not, I'm the person who can help them, get a little bit of money or get a little bit of quality of life improvement through resources or other benefits. Every once in a while, another professional will sort of butt in to my conversation with somebody. You're nodding back there. Yeah, and it's like,
so I know.
Yeah, it's like, and that sort of also shows that the person doesn't necessarily value the role of social work. I actually had a research person do that once, and finally, after that happening enough, I went to him and I'm like, when I'm meeting with someone, could you please, let me know, or can you please just wait, basically is what I asked for. And he ended up, I think, being pretty embarrassed about having interrupted and trying to just walk straight up to the patient and give the consent for research. Yeah, while I was talking to them. I think he ended up being kind of embarrassed, and I had to do that another time with a research person too. I don't know it's a different, I think, I don't know, a different culture or something. But that's where we have to sort of be confident and brave in some ways and saying, no, what we have to do is really important as well. Let's, to each person their own time, basically. And then sometimes a challenge can be that, there's that hierarchy again. The doctor's time is the most important. And in a lot of ways, it is very important because they have very limited time. They have tons of patients to see. They have a lot to do. But as I've gone along, as I've worked in this bone marrow transplant job, I even have the doctors go, I'll be back later. I'll go to my next patient instead. So that's, yeah, it's been really good. Like I think, but that's the thing. There's a lot of, you gotta be patient and kind of prove your worth and not get too upset about it when that other stuff happens. So then another challenge is, again, I said this before, the patient might be overwhelmed and lack the capacity to really absorb information. So, and even providing written information isn't always helpful because they get so much written information from medical providers of all different sorts. That can just be a challenge. I can't tell you how many times I've documented that I told somebody about a resource or something that they could benefit from, and they say they never heard about it before. So, I don't know, I have this attitude of, okay, well, I'll explain it again. And that's what I tell people that. I'm like, you don't have to remember all of this. Here's my card, call me when you want me to repeat it, and I will repeat it as many times as you need me to repeat it. And not many people take me up on it, but a few do, and then they get something done, you know, that really ends up making their life a little bit better. So like I was kind of saying, I feel like you just need to let go of expectations that people will understand what you're talking about all the time, or that they will take action on your recommendations. You're just introducing the menu of options and kind of facilitating what the person wants to and doesn't want to do. And then later that might change. So I just kind of, I don't know, at work I have so much patience. I wish it would transfer to home. But a little bit better than it does, but I'm just like, okay, I'll repeat myself again. Yeah, we can do that again. Okay, I'll talk to you again. Yeah.
So this is going back to something they were saying earlier about sort of the hierarchy and sort of the value of your profession. And can you speak at all to your experience, for example, rounding on patients where everyone's giving their input and sort of what you bring to the table, and maybe if there was any struggle earlier in your career of finding your voice among these other interdisciplinary folks and sort of finding that strength and confidence that you're mentioning?
I'm not sure I understand the question. So you're saying, first of all, I don't really round with people. I'm saying that's something you could do. I have a conference that I sit in on every week where we talk about all the patients. So it's a once a week sort of rounding. And I'm still kind of working on having a voice in there. I find like the other day, I guess it was last week, one of the doctors was saying, oh, he was sort of all torn up about whether or not to offer a patient that he had already given an allogeneic transplant, another allogeneic transplant, because he felt he hadn't given her like good enough cells, basically. But he didn't know, because her health wasn't really great, whether she'd want to go through all the testing and the rigor of actually doing the transplant and stuff again. And I said, I'll sit in with you on that conversation. And he's like, it's okay, I got it. You know, like, and you know, my purpose wasn't to say, oh, you can't do it, because I think that's how it was a little bit interpreted. It was more, I can be there for longer than you can and sit there and help pick up the pieces and figure out where the patient wants to go. And he was talking about doing all this testing without even asking the patient whether she wanted to do another transplant. So it's still working on it, I guess. I think it's a really long process. Yeah. Yeah. And it's couched in good relationships with your team members. And we have, I have to admit, we have kind of a team of difficult personalities. So it's taking a while, yeah. Did I sort of answer the question?
No.
Okay. Okay. Oh, the other thing I said was a challenge was you're sometimes advocating for like patients' desires and wishes when the doctor or medical professional doesn't think that the patient needs what the patient wants. And sometimes your job is to educate the patient on, you know, kind of in lay terms why their requests are being denied. So, you know, it'll depend, you know, on your professional judgment whether or not you kind of go to bat in an advocacy role or whether you're more in an educational role. And it could change, that could change by the day too.
Can you give a practice example of it? So it's kind of a melding of what Angela was saying and what you just said, of a situation where, you know, a doctor, maybe a doctor and nurse are thinking to go one direction, but you already have enough to know that that may not be a great direction to go. Mm-hmm. Or you feel like, you know they haven't really talked with the patient. So how do you then, you know, go about either letting, you know, giving the information that you do know, and how do you get it to where because we have to fight for our patients, right?
Yeah.
It's time. So how would you handle that?
Well,
or how have you?
Actually, after that conference, when the doctor sort of was like, nah, I was like, hey, you know, I'm just wondering, have you even asked her if she wants to do this? And, you know, here's what, you know, I explained to him why I had offered to be in on the conversation. And I don't know, I just tried to one-on-one explain to the doctor. That's what I did in that case. And I don't think, he must have met with her by himself anyway. But I feel like that's all you can do is offer and explain your reasoning, and hope that someone will take you up on it. Yeah, I don't know. I think somebody else might just insist, but I don't do that.
And I don't think there's one way.
Yeah.
One right way.
Yeah, I think it just depends. Yeah. So other challenges that I had here, and I do have some cases that I'm going to talk about, is that there's always that push and pull between what's best for the patient and what's best for the system, and you're always stuck in the middle, and that gets taught in social work school too, but it's so true. You've got many masters, and if you want to keep your job, you can't always just do exactly what you think is the best. Ideally, that's what you would do, right, as a good social worker, but everybody has to also think about their own kind of self-preservation. So I don't see a lot of that happening where I'm like, ooh, the system is totally wrong. But every once in a while, it's kind of a struggle. And then you kind of feel like, ugh, it's countering my ideal as a social worker, and it doesn't feel good. But it's a tough decision you sometimes have to deal with. Another challenge is we tend to be compensated a little bit lower than other people with a similar either level of education or people with fewer years of education, like bachelors in nursing. The nurses who have bachelor's degrees make well above what the masters of social workers do in a hospital. Even RNs with associate degrees make a fair amount of money more. So this is not necessarily a job that you do because you're looking for lots of money. It's something you do for personal satisfaction and to improve quality of life for other people. Sometimes the other professionals think you know and can do anything related to mental health or whatever their vision of social work is. And I'm just really clear with people that I know some things about mental health, but I am not a therapist. I can't diagnose because I can't. And so I think it's really important to kind of stick to your guns, so to speak, as far as your training and your scope of practice is concerned. And also, a lot of times the nursing home social workers are the ones who go looking for people's dentures. Like, that's not really your job, If you really, and I struggle with, okay, well, if you have the time, maybe it's okay to do it. And on the other hand, maybe it's better to set that boundary and not do something outside your scope of practice, even if it seems like it's not a big deal. Again, that might depend on the day or the person you're working with or a lot of factors. And then the final thing that I think is a struggle in medical social work is your boss often is not a social worker. My boss has been a nurse almost exclusively throughout, maybe half. I guess half my professional life has been having a social work boss and half has been having a nurse as a boss. And when the nurse is the boss, they just don't really understand what we do. And they don't, which is actually also sort of a positive, because then you can sort of create the role that you think is appropriate for social work. But you can't use your boss as a clinical supervisor for social work. And they can't really advocate for you as a social worker. So it's a push and a pull. So perks of the job. Like I said, my boss isn't a social worker, so I get to sort of educate her in what I think the role is and what the values are and introduce the code of ethics as necessary, et cetera. And frankly, I feel a little bit less anxious about how she's going to evaluate my performance because she doesn't know exactly what I do. So I don't know, that's not necessarily a plus, but I personally make sure I have other mentors and other folks I can be in touch with, and I think that's important for everybody. So if you don't have a boss that's a social worker, that's yet another reason to find a mentor or find somebody in the profession that you can talk to on a regular basis. My particular job allows for a lot of creativity. When I started as bone marrow transplant social worker, there wasn't really a bone marrow transplant social work program. So I've created a pre-transplant evaluation. I've created the follow-up post-transplant. I've started working with people on the inpatient side of things. I've started working on a more interdisciplinary level with some of the nurses. So it's nice because sometimes you can be creative. Well, actually, I think almost all the time you can be creative if it's at least just problem solving. I have had time to do some special projects. So like I've gotten to work with the Association of Oncology Social Work and do that quality improvement project where I kind of assessed how people were doing after their transplants with the National Comprehensive Cancer Network's distress thermometer. It's this one-page tool that oncology professionals can use to kind of see how they're struggling in terms of their psychosocial, spiritual, emotional, and physical selves. So I've been able to sort of pinpoint, okay, boy, at this point after somebody's transplant, fatigue is the biggest problem. Like, it just is. Right after transplant, everyone's just so fatigued. But then like finances are usually like the second thing because they're starting to worry about having a lot of time off of work. Or what if I can't get back to work when I thought I was going to? What if I exceed the 12 weeks allowed under FMLA? Will I lose my job? So that comes up a lot. And I got to attend this Excellence in, it was called Excel, Excellence in Cancer Education and Leadership for Social Workers, with the City of Hope, which is a well-known cancer care center, and the National Comprehensive, National Cancer Institute, NCI. They funded this program to teach social workers how to be leaders, and that's what this quality improvement project came out of, was attending this 2-day workshop where I was assigned a mentor, which is the professional Tracy was talking about, who is a professor at University of Michigan School of Social Work. And it was it just totally changed the way I view leadership in social work and the responsibilities of social workers and my practice as a social worker. So if you ever get the opportunity to attend sort of one of those like really great development workshops, do what you can to attend them. I like that I get to work with the full span of adult life from age 18 to, actually my span that I get to work with is a little younger because of bone marrow transplant being a treatment for kind of younger people. Like the upper level now is 73 or 74 where they'll give somebody a transplant. It used to be that they wouldn't give people over like, I think it was like 40 or 50 a transplant. And that age range has expanded incredibly over the last like maybe 10 or 15 years, that they'll go up to 74 or 75. I'll see a few people who are a little bit older than that, just under the sort of hematology umbrella. But in any case, it's nice I like getting to work with this whole span of life, because people who are 18 have very different concerns than people who are in their mid-30s, who have very different concerns than people who are in their 50s versus the people who are past retirement age. There's just like, if you're 18, you might be wondering, oh my gosh, how is this going to affect my ability to date or find a spouse or complete school? Oh my gosh, this treatment has put me so far behind in being able to get my degree or being able to keep up with my peers, and now I just can't. When you're in your mid-30s, it might be, oh my gosh, I have little kids. How am I going to make sure that they're well cared for in addition to me being cared for, in addition to my spouse or partner being cared for? And how am I going to get back to work so that we can financially make it? And in your 50s, it's more like, well, my kids might be grown up, but I still have a house to pay off or a car to pay off or whatever I need to financially be responsible for. Plus, I'm way too young to die. I feel like that's when you think that more than when you're younger. People think the I'm too young to die thing in their 50s more. And I think it's because it's like, well, yeah, you could be old enough, but really it's too young. And people aren't quite retirement age yet, so they can't access their retirement benefits yet. And So it's interesting the different challenges you see at different points in the lifespan. And my day's never the same day to day, and I love that. I love that I have the opportunity to do things like come here and talk to you, or engage in these special projects, or just meet different people every day. And I like getting to learn from colleagues who work in different professions. That's really fascinating and helpful to me. I like that I get to work in this academic institution, so UW Health, and so I have access to all the academic journals and paperwork and seminars and things like that that you wouldn't necessarily have in a non-academic environment. And the nice thing about working where I work, it's a large place, so we've got, I think, more than 60 social workers there. So it's really nice because there's a broad range of experience there, potential mentors, and then also working with the Association of Oncology Social Work, you've got access to thousands of other social workers who may be able to help you out with a particular need or issue. That's kind of the prepared part. I have some cases I thought it would be fun or interesting to talk about to illustrate some of the stuff that I do. But any questions before I do that? Oh, either way.
Are you ever on call, or do you have to be on call?
I would say most of the UW social workers do, but those of us who work in the outpatient clinics, which is where I primarily work, don't have to, no.
Hospitals are such busy places, and I hear in a lot of circles, a lot of emphasis being put on trauma-informed care. I mean, with as much going on in the hospital as there is, how much attention is being paid to that these days?
To trauma-informed care?
Someone has a trauma before they come in.
Yeah.
And quite often, for instance, taking someone's clothes away might be very traumatic to them.
Yeah.
And yeah, so it's very important in some circles. There's a guy at a DHS whose whole job is dealing with trauma-informed care.
I have to say, I think I've heard the term, but it's not a focus where I work, and I think that's, it sounds like a really good topic or subject to be focused on, because you're right. I think I just sort of intuitively do some of that, where before the transplant I say, hey, if you want to wear your own clothes, you might have to modify them, sew them in a different way, because some people find it very important to wear their own clothes. You're right.
That's just one example.
Right, and other people, I warn them, coming back here could trigger some feelings of trauma.
That's what I mean.
Yep, and I think we recognize that there is trauma, definitely, and my whole experience is either in hospice or cancer care, but I think we recognize, that you can really experience some trauma from your care, from multiple levels, but I think we could proactively address it better.
As well as trauma from before that's re-triggered by being in a similar instance.
Yeah, absolutely. Yeah, I think we kind of understand it, but we don't proactively address it very well, no.
Thank you. I just wanted to know that.
Yeah, I think there's a lot of places to improve the way we care for people, a lot of ways, yeah. And thank you, because I will look into that a little bit more, I think.
I know a lot of people who like that, when you say that.
They what?
I deal with a lot of people who really appreciate when you say something like, I'll try and be more attentive to it.
Yeah, okay, good.
Thank you.
Yeah, well, thank you for bringing it up. So these cases that I sort of brought up they're all cases that have either helped me really learn something or have changed the way I practice. Actually, I think this one I'm going to jump to kind of addresses some of this trauma-informed issue here. I worked with one patient who, it was a man in his 50s, and he was married to a woman about the same age, and he had had an allogeneic transplant, meaning he had the risk of that graft-versus-host disease that could impact his quality of life or potentially endanger his life. He ignored symptoms of graft-versus-host disease and was hospitalized, and ultimately, essentially, bled out of his GI tract and died. And in the process, he wasn't able to communicate with his wife the PIN number for their bank account, and he had never shared it with her before. Yeah, I know. And, you know, like, I don't know why, but the account was only in his name. He just managed all the finances. He tried to communicate the PIN number to her, but was sort of delirious or unable to communicate well, and she tried every different combination she could think of and could not access their money to pay their bills. So, having had that experience, I now have a list that I found. I found it online. There's this list from, I think it's from the Wall Street Journal, it's called the 25 documents to have in your death dossier. It's something like that. But I renamed it because everybody's so, they just don't want to talk about death. Even though, and I have doctors that I work with who will go either way. They're like, Kristin, you got to make sure that you know their funeral plans. And then others say, oh, no, let's talk about death. Even though we know with the allogeneic transplant for acute leukemia, you have a 30% chance of surviving 2 years or more. It's really low. So you really should be thinking about your end-of-life plans. So that's what I do now, is ahead of time, I give them this death dossier, labeled a different way, that tells them to share PIN numbers, passwords, account information, location of documents, birth certificate, social security card, discharge papers from the military, marriage and death certificate, or marriage and divorce certificates. And then at the bottom of it, I just sort of think, oh, well, people who don't want to think about it will just sort of skip it or skim over it. But at the bottom, it talks about making funeral plans and making sure somebody knows what your wishes are in that respect. Some people are super open about it, and you know, actually I use some of the stuff that I learned in your study, Tracy, about the protective questioning. You know, so where do you think this is going, or what do you think the final outcome of this could be? And if people go, well, I might die, well, that kind of opens up the door to talk about that. And I would say it's sort of more people than not say I might die, but some people just don't want to go there. We have to respect that. So that's one case. Another thing that I make sure I talk to people about now is, so I worked with a patient, also had an allogeneic transplant. See, this is just the most risky treatment in terms of bone marrow transplant. She must have been in her, I think, early 60s. And it turned out that she was the guardian, like legal guardian for her 4-year-old granddaughter. And nobody really knew that until after she died. Yeah. And she also had her own mother, kind of as a support person and caregiver for her. But this 4-year-old granddaughter was sort of left without a guardian when her grandmother died in the hospital. So now I kind of try to proactively ask, are you a guardian for a minor child or an older adult or somebody who might need a guardian if you weren't able to perform that role? And yeah, sometimes people are. So I start asking about backup plans and what's going to happen if they can't serve that role. Again, not sort of saying if you die, but if you can't serve that role. Yeah, if everyone lived in my world, we'd talk about death like all the time. But speaking of, so this, in my hospice work, well, in school, actually, we read Final Gifts. Have you heard of this book, Final Gifts? If you haven't read it or heard about it, it's easy reading, case studies, super interesting, has to do with a concept called nearing death awareness, primarily, where, people who may be considered to be having, hallucinations or something that would perhaps make you wonder about their mental health is actually just nearing death awareness. So, and of course your spiritual and religious beliefs might explain that more depending on who you are. But a lot of times people will see another person or have what seems like a dream about a lot of times going somewhere, like riding a train, or I had a guy in hospice who was going to pick up the Buick And his family's like, he's never had a Buick. And we're like, oh, that's because he's nearing death. Or I had a minister in hospice once say, I don't know whether to get in the line for going or staying. You know, and probably within 2 weeks he died. Other people I know have seen angels or been visited by their grandparents. There was a 36-year-old, I think, I worked with in hospice who was visited by both grandfathers for probably 3 months before she died. So I feel like it varies from a few days to 3 months before where you see these kind of what other people might call hallucinations or visions or have these kind of experiences. Or some people say, I just want to go home. And everyone in the family will say, you are home, if they are in their home. And they don't necessarily mean this physical home. So anyway, that's sort of final gifts in like 2 seconds. But I had this patient, now it was about a month ago, who saw me in the clinic. And when he came in, so some of the hallmarks of active dying can be that you have kind of a high heart rate and a lower blood pressure, and you're kind of real drowsy and not communicating as well. This guy was doing that. In the clinic, he had high heart rate, low blood pressure, could not keep his eyes open for the medical assistant. Well, I walk in, he keeps his eyes open, talks to me for 20 minutes. It was so odd, given what they had told me about him and that he's in a bad mood today and he was not for me. So maybe I was meant to be with this guy or he was meant to tell me this, but he goes, we talked about different things. He said, I finally got my Social Security approved, and I finally, I don't really like this rehab center that I'm in because I don't think they have enough staffing and they're not treating me, they're not responding to me fast enough, and so he complained a little, but it wasn't angry. It was just disappointed. And then he said, kind of looks around and he's like, can you keep something confidential? And I was like, well, I did the whole, if you're going to hurt yourself or someone else, no, but otherwise, yeah. He goes, well, I've been seeing things out of the corner of my eye. I feel like somebody's standing there. And then I'll turn and they'll be gone. He said, or I'll say, hello, and they'll be gone, by the time I turn around. And based on what I'd heard about, how he was doing, I said, well, do you feel like you're getting better health-wise or like it's getting worse? He's like, I don't know, about the same. But he'd been just really sick, and he had graft-versus-host disease as well. And I said, well, I don't want to freak you out. But, sometimes people think sort of seeing things like that is basically nearing death awareness. And I said, and it's sort of somebody from the other side just sort of saying, hey. I said, you wanted me to keep this confidential because you don't want someone to think you're having hallucinations and stuff? He's like, yeah, I don't want more medicine. And so I was like, okay, fine, we don't have to tell anybody about it. And I did keep it confidential from his team. I just said to them, I think he's getting close to dying. And they were all kind of like, bah, we're going to give him some more medicine, which is what they did that day. 2 days later, he died. Yeah, I think that was nearing death awareness. It was really, once you see it, you kind of know it, very interesting. And then the last case that I wanted to kind of talk about that was interesting in a different way, this is also a patient who needed an allogeneic transplant, had an acute myeloid leukemia, which is one of those very risky leukemias that you can die from quickly if you don't get the treatment that you need. She's actually in the hospital right now. And she is, I think, 28 or 9 years old. She moved here in October from Algeria to be with her husband, who won the permanent residency lottery and was able to come here. I think he came here about 5 years ago. He's been here a long time. She just joined him. But they've been married for about that long, about 5 years or 6 years. And she needed, we determined, her doctors determined in Algeria that she needed a transplant, and for some reason she didn't trust the medical system there. And it sounds like it was hard to get information from that medical system here. But they determined that her brother was a match for her to be a donor for bone marrow transplant. And so he applied for a visa to come here to be a donor for her, and even got sort of an expedited visa appointment, and they turned him down. Yeah. So we searched on the registry, we searched whether there was an alternate donor, we asked her whether she would go back to Algeria to get a transplant. No, 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 no. So I ended up working for about 5 weeks with Senator Tammy Baldwin's office, and we were able to, I mean, it just looked like, you know, he kept, the guy who was helping me there was like, you know, even if we can get this expedited appointment sometimes, even if it's for humanitarian parole, and I'm like, oh my gosh, it's like we're letting this guy out of his prison of Algeria to come here? What is going on? Humanitarian parole, even if we get that, it might take 3 months or more. This woman needed a transplant like in the next 8 weeks. So we worked on it. We just every day kept accumulating letters and evidence that this man had a reason to return to Algeria, and that he had family there, and that he had a business there, and that he would be, you know, would not become a burden on our, you know, it's just, ugh, the whole immigration system is just yuck. We won't get too political though. But ultimately, after probably 5 weeks of working with this guy every single day, the brother got an appointment, and he is here now. And he did become her transplant donor. It was like, that's like one of my biggest victories, I feel like, ever. So it was so much, it was just like a lot of convincing and a lot of letter writing and work, but it's very interesting to learn about how the immigration system works and how the senator's office can help, and how we can get the impossible sometimes done. So she's recovering. Hopefully she will be fine in the long run. Yeah.
So we are at time. I know I gotta go teach. Now that we have a class. Does anybody have a final question?
If it can be answered in a couple of minutes, I'm interested in what about the Excel program changed your whole view of your social work role, and whatever it is it something we should try to include in our social work curriculum?
Ooh. I think for me, a lot of it was, I was already very motivated to go, so that's part of it, but they somehow it got through to me that leadership doesn't come, it comes by earning it and by example, not because somebody puts the title of leadership on you, and that also includes this evidence-based practice and becoming involved in research, and that how important those things are, and how and actually also the confidence piece, that, you know, you just need to somehow convey this confidence. I have lots of the materials from the course if you're ever interested in getting them, but I wish we could somehow, yes, that would be great if that kind of information could somehow be incorporated into the curriculum. Those teachers were also very, Shirley Otis Green, have you ever heard of her? She's I think her name is biggish in oncology social work, but maybe not outside of it. She's just a very dynamic speaker. She makes you laugh, she makes you believe that, like, social workers are the greatest ever, and, like, you know, she's very motivating. So that's a little part of it too.
Thank you.
Yeah.
Okay.
So Tracy's gone, and there's no one around to say thank you. I'll say thank you.
Yeah.
Actually, I'm